ଏଠି ଦୂର ନଥିଲା এটা সেভ হবে তো हाँ এটা শেয়ার कर दिए लिंकটা मैम को कॉपी
but she did not respond to this so maybe the surgery that you shared in the group say the
Yeah, so people with myasthenia, ocular myasthenia, children which are diagnosed sometimes may initially respond to pyridostigmine and then with time not respond that much. Or there are some very few though who would not respond at all. So basically for recalcitrant ocular myasthenia, you can do surgical correction. So surgical correction, otherwise the generalized teaching is myasthenia is possibly the only cause of ptosis which has a medical name. But in recalcitrant myasthenia, one can think of surgery, but with surgery, in a situation like that, or let's say if it's a chronic progressive external ophthalmoplegia, we would more often than not depend upon nasopharyngeal sling with silicone. Because of certain advantages silicone gives. Silicone gives the advantage of reduced lag off, where exposure is a major problem because these patients will also have bells not as good. So exposure, so you want because it's elastic, we need to remember that most of the time the orbicularis is okay, except in CPO even orbicularis is weak. But if orbicularis is okay, then when they squeeze the eye, the silicone expands and they can close the eye. The other big advantage is reversibility, or in fact adjustability. Even 10 years later, silicone is one of the few materials you can open up, adjust again and again, keep it. And the correction can very well be titrated. These advantages are not there which we are doing the partial outcomes. So usually in a situation like this, you can do a tarsofrontal sling with the correction with silicone. The only difference is don't try to probably do a predetermined under correction. That means you just clear the visual axis. That's something important.
link
To serve the purpose. Screen usually set it here. Will it not serve? You all set up now here.
ना हो जाएगा सर
no problem
No, but audio it was जो ऐसी वाली
So with the microphone. No, but it doesn't reach
so
you, na?
एक तो मुझे पता है ले will the mic be able to pick up without
थोड़ा connect कर दे.
ऑफ करके स्टॉप करो अच्छा हो गया
शेयर कर देगी ना? ठीक है तो फाइनल.
यस मैम ठीक है सर
So, good evening, everybody. I had in mind to talk about a particular technique of endonasal DCR, which is actually done without an endoscope and also without a laser. This is a technique that I learned in my stint when I was at under the mentorship of Professor Peter Dolman in University of British Columbia, Canada. And I think some of the advantages it offers is it actually gives you the best of both worlds. Uh, what we are going to talk about here is some of the relevant nasal anatomy. We'll talk about selection of patients, what are the instruments that we use and some tidbits about that. We'll definitely see the surgical technique, what are the outcomes. We'll talk about a few complex scenarios, and actually this last one is a no because that will be completely different, and that's a conjunctival DCR, the Jones tube. So that's not something that we're going to talk about in this. On the anatomy, I think the key thing to remember is actually that when you're talking, so the blue here is actually this is the real skull, and the blue is actually this is all being done with the help of Play-Doh and is representing the lacrimal sac. And I think the key thing for anybody to remember when you're doing endonasal surgery is that most of your sharp instruments are pointing towards the eye, whereas in an external DCR, most of the instruments are directed away from the eye. So there are some particular complexities that can arise because of this orientation itself. You see blue here. So if the instrument is connected to the navigation, it gives you in real time uh, the position of the instrument. That means the tip of the instrument in coronal section, which is the top left. It gives you in the sagittal section, which is the top right, an axial section, which is the bottom left, and also in 3 dimensions. So it essentially gives you a huge advantage on the particularly on the important bony landmarks. One disadvantage of this high-tech gizmo is that it the soft tissues tend to move. So the bony anatomy is very fixed, and after you've registered, if you were to actually ascertain where exactly is the cribriform plate, it would be very helpful. But if you want to try to find out where's the nerve, when you are trying to retract the tissues, the nerve may have moved. So that's not very good. Uh, I think one thing which was here is actually try to look at the tip, and you will actually see the nasolacrimal duct appearing here in a coronal section, and also showing that's the nasolacrimal duct showing on a axial section, and that's the NLD actually, the nasolacrimal duct itself. So I use this basically to get an anatomy and a relationship on a CT scan too. Coming to what we are going to talk about, this positioning. Now, positioning in a non-endoscopic endonasal DCR is a little bizarre. It's like you see, you've got to use a loop, a surgical loop for correction, and based on a working distance. It's the same loop that I use. It's about 3 times magnification. It's got a 50 centimeter working distance. But you are most of the time you're going to do the surgery in the opposite side, and there's a light pipe, and this is pretty much the position. Positioned well, you'll have to go by the conventional, time-tested technique of keeping the head end position a little high to make sure that the bleeding is less. And the opposite side is what I mentioned, and a very simple set of instruments, which I'm going to show in the next slide. This set of instruments is all that you need for non-endoscopic endonasal DCR. You need a cold light source, which is on the left side here, the box. But the cold light fountain can also be, in the worst come scenario, the light pipe that we are using, which you see here in the middle, is actually the same thing which is the Alcon endoilluminator. Which means that if you happen to have colleagues who are doing retina, then the endoilluminator can very much become the light pipe that you can use and can get attached to the same retina instruments. But a cold light source is much cheaper and easier. The first one that you see is actually a very important one, which is the nasal speculum with a guard. Now that allows your hands free. Why it is important? Now, a lot of times when you ask people who do endoscopic DCR, a sizable number of patients, they would actually do a septoplasty to gain access and then do the DCR. Now, most of the time, because of this instrument, the soft tissues are so spread apart, we never have to do a septoplasty. That's one advantage. There's a nettleship dilator, a lacrimal probe. That's a lens spatula you commonly use, a periosteum elevator. That's a sickle knife. It's a wheel Blakesley forceps or ethmoid forceps. You have upbiting ones and straight ones. And I usually use 2 rongers. One is a 90-degree 3mm ronger, but all instruments in endonasal have a longer shaft. Right? They have a longer shaft because you have to go into the nose and manipulate. And this one is one of my favorite. Is actually a 45-degree. It is a rotating ronger, and you will see it in action in sometimes in the video. It will actually go in 8 different positions and do. Okay. So suppose I am going to try to take a little bit on the right hand side. I just have to turn it, and it turns. So it comes in 8 different oblique positions. So this is the set of instrument. That is all that is needed. The surgery shown as high resolution pictures. Essentially, what you do is you put the light pipe into the sac. Now, when the light pipe goes into the sac and hits, and you get a hard stop, then essentially it shows on the picture on A. You see the light spot there. After that, keeping that light spot, you make an incision. Now this incision on the actually mucosum and periosteum together, so you actually make a mucoperiosteal flap, is something that these days we keep and kind of oppose. So important thing here is because the light pipe, see, one important thing which is important here to highlight is that we are not uh, taught to understand and become conversant with the nasal anatomy. So from ophthalmologist point of view, to have actually a light pipe is an important landmark because essentially what you need to reach is the lacrimal sac. The let's say the ENT guys are a lot of times are other landmarks, let's say axil of the middle turbinate, the unseen process, and basic which they do use identifications. But it's very important for ophthalmologists because you are actually using something at the light at the end of the tunnel to go towards. And you will see that in the video too. After that, this is the mucoperiosteal flap, and this is the bony osteum being made. We will see all of this in the form of yes, the tract transillumination. The light pipe has already been introduced, and you see it very clearly on the arrow. Before you want to start the surgery, we usually would give injection of like we use today. Uh, Now look at something what I'm using a lens spatula to medialize the middle turbinate. Right? A lot of times the middle turbinate is banged there, close. So create a little space, and when you see the middle turbinate up front, you would actually be looking at possibly what would be in the ethmoid region. Right? So the light pipe is right there, and we use inject to blanch, and the blanching of the blood vessels is seen very clearly. Another important thing is because the light pipe is right there, you know exactly where to start. So the location, there are variations on the location of the lacrimal sac too, just like there are variations in anatomy everywhere else in the body. So this one, it is an important thing to look at. Once done, then essentially we have reflected the flap. We have reflected the entire mucoperiosteal flap, and what you see is holding onto the suction there is actually the mucoperiosteal flap, a thick chunk of tissue. It's a modified technique that I do these days. This is not how I was taught, but essentially I feel this has really helped, and I'll talk about it. How exactly does this flap come into improve outcomes? Create an optimum bony osteum. Now remember, the light transillumination was happening because of three layers, the light passage. The mucosa of the lacrimal sac, the bone intervening, and also the mucoperiosteal flap. So the mucoperiosteal flap is out. So obviously light transformation is more. And you see the bone right there. Now, somewhere in the lower part of the bone, somewhere around the body of the sac, it's a good place to actually start the bony osteum. And I'm using the standard 90-degree 3mm ronger to actually do this removal. And you will notice slowly I'm trying to go into zones of bone which have not been touched upon. Now, as in external, it is important to wriggle your ronger between the sac and the bone. Right? You don't want to damage the sac as yet, because if you puncture or damage the sac, the rest of the surgery becomes a little more difficult. It's still possible. Okay? So, this is how what we achieve first. And like you may have seen in the light pipe movement, we very clearly can see that as you start taking more and more of bone, the light in the sac becomes more prominent, and it starts tenting out too. Now, when the surgery is being done, you don't have the advantage of the endoscope. The picture has been taken with an endoscope. You don't have the advantage. That's an advantage. Why? Because it essentially is light, which is progressively becoming more uh, prominent when you are removing. So anything that is obstructing the light shows us the dark structure, which may be the bone in this case. Exactly where we left. Now you see I'm trying to move the light pipe, and actually as I move it, I see different sections, and it's clearly that the upper part of the bone is yet to be removed. It's very critical that this bone actually is removed. Now here Usually in the upper part there is more cancellous bone, meticulous removal is needed, and various set of instruments can be used. Sometimes you can use a rotating launcher, which I am doing here, and by taking it in different positions, that bone could be removed. Sometimes in more challenging situations, you may actually use even a drill to do that. And and in my own experience, I feel what the drill does is not necessarily take out all the bone, but actually tends to thin it out, make it more easy for the ronger to work. A set of pictures to essentially show what. Now this particular is where the upper part of the bone has already been removed, and what I'm trying to do is tent the sac and then try to make an opening. Now here, keeping the the thing that we showed, the mucoperiosteal flap, which is already there from the nasal mucosa, this particular one we want to make a large posterior flap. It's exactly the opposite of external. You want to make a large posterior flap because you want to come to bring it to apposition. So we'll move on to the next one. Now after open of the sac, you actually see this at the edges of where my cursor is running is actually the posterior flap. And that posterior flap, there are various things that I can do. In this particular one, I'm actually fixing glue behind the posterior flap and fixing it to the lateral wall. So what do you have? You actually have a lacrimal sac which has been opened up, and it is a marsupialized disc of the sac, which then heals and gives you a clear passage. Okay? So this is one way of doing it, which we used to do earlier on. And when we did this, I think the success was pretty good. But in those patients who had a small sac, a fibrotic sac, and particularly in pediatric age group, there were challenges because the granulation tissue from the secondary intention healing I was talking about was becoming a challenge. Right? Now, we've done irrigation. Most of the time when we're doing irrigation, we do it from the lower canaliculus, because we want to ascertain how nicely the fluid is coming into through the sac. Now this particular video is interesting because try to look. This is where the light pipe is coming out. But you have, based on the way we have made, we have a large anterior cuff which we need to take care of. Now this edge is too close to the opening of the common canaliculus into the lacrimal sac. So, and unfortunately this is too small tuft of tissue to be taken by a soft tissue debrider. So, is actually sort of doing things which instruments are not really made for, but I'm trying to take that small extra cuff of tissue with the help of the same rotating launcher. But the key thing is, it's a good idea to prevent this by trying to tent the sac and make the opening very anterior as you can along the bony osteum. There's some residual bone which is also there, which I'm trying to remove with the rotating launcher. The idea is, wherever the light pipe is coming out, at least a couple of millimeters above that should be opened up of the sac. Now this is, of course, we saw something, irrigation to confirm the patency of the sac. This is the light pipe, and while you want to do this, initially we put the light pipe through the upper canaliculus, so it's an oblique orientation. But when we are doing this, we are actually placing it horizontally through the lower canaliculus to make sure that all of the fundus of the sac is also open up. Okay, so that's something that we do. This is where we place MMC, and we actually have a particular randomized controlled trial. We have sort of analysis of the results out, but I can share here that overall it was about 440 patients in two arms, where all of them had tubes, but endonasal DCR with this technique, and half of them had MMC, half of them did not have MMC. And the best part was, patients who had MMC and who did not, it actually matched up. That means MMC did not show any. Most of the literature today, even large meta-analysis done by even the Cochrane review, if you look at 2019, they talk about that MMC helps. But our is a single center RCT, and we find it does not help and it tends to give the same, but we are talking about patients who are primary acquired nasolacrimal duct obstruction. So no revision cases there, no secondary obstructions there, no pediatric and all that. Moving on, this is what I wanted to do. Today what we do is the earlier flap I showed and the sac flap. Take a close look at what I'm doing.
How much of MMC did you use in that study?
In that study, it was the protocol said we were supposed to use 0.04% for 3 minutes. Application just like this. So we did that standard for all. And just one quick anecdote: when we went, this study actually ran for 8 years. 8 years, 440 patients. COVID was a huge challenge to get patients back to look at follow-up and all. But one big thing is, when you're doing an RCT, even the surgeon who is doing it might be biased. That MMC will help. So if he is biased, it is possible that when he is doing the surgery, patients who are being operated for no MMC may be done differently than the patients who are with MMC. So you have what is called randomization sequence, and it is that means the surgeon doesn't know whether it is A or B. So there are techniques to that. It's called block randomization and things like that. But was there a possibility to keep the surgeon also, what do you call it, blinded? So my fellows, whenever they were trying to, the Excel sponge or the sponge that you see there, and put MMC and show to me, is this yes MMC, no MMC? I would always get it right that this is MMC. So there was no way it could be blinded. But we had allocation concealment. That means I reached up to a stage where irrigation was clear and okay. Only then they would open the envelope and say it is A or B. And then of course MMC or no MMC was decided. So this particular one is where the flaps are, and what I'm touching now is actually the flap which is the bucco-periosteal flap. And the light pipe is coming in, that end is actually the flap which is the sac flap. I will go a little bit further because it is more magnified view just after this. And what you see here, it's a little light pink is the one which is bucco-periosteal flap. So we are bringing both flaps very close to apposition. And how do you fix it? Now, very few surgeons in the world actually, endonasal, actually do a suture. You may also sometimes use clips to keep them together. In our situation, I've tried doing sutures, but it's really difficult so deep to take those sutures, particularly with the left hand of not being able to use and fix the tissue. What we do is fibrin glue. So you will just about see that both are in apposition, and I'll use fibrin glue to keep both of them opposed to each other. That's the magnification. And so the junction would be somewhere here. That's the junction of the two. Okay? And for glue, I mean, it's both the fluids are placed at the site of the junction between the two, and we leave it for a while, and that's how it works. If I were to ask whether, I think flap apposition has really helped push outcomes to almost 95% now, particularly important because the pediatric group with their aggressive granulation tissue was showing lower outcomes in this particular study, and after that we changed this technique and has held good. And I think the flap is a good thing. And it's also about extrapolating experience from external to endonasal. Some of the new, if you look at the literature of outcomes for endonasal DCR, it's actually parallel with external today. Many studies centers will tell you we could get good of 90-95% compared to external. So I think this is where there has been a huge change. That's about the technique. So any questions up to here, I'll be happy to take.
The application of glue, when you're applying the glue, would it not spread over to the surrounding structures?
It would, but fibrin glue is supposed to be extremely, I would say, friendly to ocular surface and multiple other surgeries, and it doesn't cause any harm. The key question now is whether it stays that way. We After we do this, we are looking at the healing time by serial endoscopy. Is the healing time earlier by doing the flap? Because we are talking about primary intention healing, and a good thing to do would be actually look at is the healing within a month compared to secondary intention healing, which would take longer. So, but I have for a long time tried to uh, suture them, and so far no. Yeah, you had a question.
So, how much difference is there between the amount of apposition that happens following a suture and that of a fibrin glue? The strength of apposition, does it vary much or is it almost similar?
I think so here because I it's only once or twice that I've actually managed to suture, and that's also with a different suture which are called they have got they interlock. If you pass a knot with it, it'll pass and it'll not move any further. So I don't think I can really do a comparison in this. But generally, if you ask, if you don't have any tension on the wound, then fibrin glue works great. If it's something that you want to bring and keep it taut, then suture works better because fibrin will not have that kind of strength to keep it together.
So then it would be preferable for the conditions you mentioned like pediatric age group, fibrotic sac or means where the flap cannot be longer. The conditions you mentioned previously where we cannot go for a long flap. So there you can prefer the sutures.
Suture, but the challenge is not the thought process of the theoretically suture is better. The challenge is technical demand of doing it. It's very difficult in a very constricted field. That's the challenge. So I would very much like to do it, but I have not yet reached that. Any other questions? You had a question.
So, do you use MMG after that trial?
MMG and MMC.
Sorry, MMC after that trial.
If you were to, it's like the trial results is something that only we know. We are in almost final stages of writing up that manuscript. But today, in primary acquired cases, I'm tending to not use the MMC. Hopefully, I would completely be done with it. But I can just tell you that before the results actually were analyzed, I had not seen the fine print of it. But generally, the outcomes were a little better in the MMC group. And based on that eyeballing of the data, when the trial was over but the analysis was not yet done, I was always trying to put them in. Just shows how biased people can be. And that's why it's important that an RCT is done. So, but yes, the trials tends to show and answer an important question. It's just that it goes against against a myth that it helps. Okay, so we move on some outcomes, and this is the first one that we had published 134 cases, but 134 cases were a mix of primary, pediatric, everything together. So that was, and just to give an idea, that's 2003, 89%, 12-month follow-up. This was very good, 95% data results. This is from Iran. And there's a Thailand group which had about 92. But this was interesting because this particular group from Thailand actually had people operating upon intranasal DCR by residents who were not trained in intranasal DCR. So it was quite different. And they actually said that residents were quite comfortable compared to endoscopic because of the light pipe. They knew where to go. So there was a teaching component to it, and that was a benefit, and that was unique in that study. We talked about this acute dacrocystitis. So had we had that particular patient, it's a convention compared to the conventional. Oh, sorry, I think the slides are running on their own. One day after, this is the result, and there was another picture. But what was critical was we compared with what was the convention. So earlier teaching in convention was give medical management and then do surgery external after 4 weeks of quiescence. The problem is a lot of times quiescence you cannot wait for, and quiescence is never achieved. If it is Pseudomonas is the organism, you do the surgery, and within 2 weeks, rather you do the medical management, within 2 weeks you had another acute episode. So you keep on waiting for the quiescence to come. What we try to do is, there are several reports like this, that you don't have to wait at all. Just start on systemic antibiotics, and within 2 to 3 days, so you have a peri-operative antibiotic cover, and go ahead with surgery. The key thing was this one. Look at the mean lag time before surgery in the endonasal group was only 7 days. And this is a group of how many? 19 patients. Whereas it was 25 plus minus 12 days for external DCR. So there was a huge time in the time to resolution was statistically significantly different. So the key thing was, though the numbers are the same, 16 out of 19, success, comparable success, early rehabilitation is the key. So looks like an endonasal DCR should be the easy thing to do in acute attacks. You don't have to go through that conventional teaching. Now this is mucocele, and a lot of times the results are very heartening. You can see because you're doing endonasally, there is no skin, scar, which is a known advantage. This was something. Some time ago, one of my colleagues in SN Chennai, they mentioned that sometimes they don't do endonasal because they feel that the ostium size is very different in external. It's a commonly held myth. So somewhere around 2015-16, we actually looked at about 100 patients and looked at least 1 month after surgery, external versus endonasal, just to look at the healed osteum. We believe that external DCR is larger. Is it actually larger? Now, how did you prove that? Now, various techniques have been described on how to get the actual size of the osteum. What we did is interesting. We actually marked the probe at 2 millimeters. And then we took a picture. Now, the picture, with the help of image J, we calculated what is the size of the osteum. Could we have done it without the probe? Actually, the picture, image J, needs an absolute in the picture. If there is an absolute of 2 millimeter in the picture, then image J can calculate if that is 2, how much is the osteum. So that is how it helped. So what did we calculate? We calculated 4 things. We calculated the largest dimension, perpendicular to the largest, the area, and area was like the this contour line that you draw, it gives you the area, and the position of the actually opening of the common canalicus from the nearest wall. Which wall was it nearest to? These are the results. In the maximum diameter, it is comparable. In the perpendicular to maximum, it is comparable. The area is comparable between external and endonasal. Even the position of the internal. The only thing that was different was the opening of the CC was more towards the anterior wall. Okay, in a patient with endonasal DCR, whereas the reverse in external, and that is quite obvious because external you will tend to go from anterior to posterior. So the position of the ostium is likely to be more anterior compared to an endonasal. But whether this will really affect the flow dynamics, nobody knows, because we are only talking about structural integrity, right? We are not talking about this. This is my favorite, and this was done by one of my residents, Dr. Rashmi Dave, who's now completed and she's in Bombay. But look at this, actually. We had a questionnaire and we looked at the functional outcome rather than the trend of functional outcome. Now, it's a common observation, a lot of people talk about that endonasal is a scarless surgery. But I feel, having done surgeries for almost a decade now, it actually is, the key thing is not the scar. Scar is anyway one of the things, but the mobility. Most of the time when I'm at post-op rounds, I would go to the ward. The endonasal DCR patient would not even be on the bed. He would be walking around all over the place. That was a common observation. And the externals would not even let me touch the eye, forget about irrigation. So based on that observation in the actual bedside, we did this, and we looked at the fluorescein dye disappearance test, the Monk score. What does both of these say? Monk score says how many times you're wiping. Okay. Fluorescein dye disappearance, you know, you put the fluorescein, you see how much is the disappearance time and compare it with the normal eye. And we looked at the trends. See, we did it at pre-op, post-op, 1 week, 1 day, 2 weeks, 6 weeks, 3 months. And you will see that both in FDTT and all, the separation is biggest at 1 day, and for FDTT, it is also at 2 weeks between the two. That means the functional outcomes is better in endonasal even in 1 day because pain is less, and also at 2 weeks. Why? Because you are not doing anything to the lacrimal pocket. You are giving an injection in external, then you are, dissecting through tissues, then you are placing sutures. All of it, we know muscles will not work the same with all this manipulation, right? Whether this is long term or short, we don't know, but at least the trends show that the first 2 weeks, that's the reason people feel very comfortable. So it's a morbidity which should be talked about to the patient, not about the scar only, which is actually a driving point for choosing between a surgery. Then we also did a question about the quality of life, and there were common questions. The question is a self-administered questionnaire. It is on in Odia. So it is called EQ5D3L. So 3 levels and 5 dimensions. And again, the separation between endonasal and external was remarkable at 1 day and then closed in by 2 weeks. So in the first 2 weeks, there was a big difference between the two in all 3 tests. And the quality of life and functional outcome, this is what. Binocular silicone stents, this is what Peter had done to compare, just like we did for MMC, yes, no. They did for tubes, yes and no, and tubes they found that there was a better outcome with tubes. To summarize, I think we talked about the surgical pearls. Outcome in chronic tapocystitis, at least published, we are looking at somewhere between 86 to 94%. We talked about acute TAC, definitely an early rehabilitation. The best part is a simple set of 6 to 7 instruments and a cold light source. And it can be, that's a question, can it be done under local, general? A lot of surgeons actually do under local. Even in our first paper, the reviewer had asked, how many patients of these did you do under local? And because of the beginning stage, there were many patients who were advised external, and then I asked them to do endonasal. There were about 30% of those patients who had done under local. These days, because of the availability of GI and the comfort level, I don't. But we all know that actually endonasal can be done under local with some precautions and things like that. So it can be. But the best part is the best of both worlds. So you are getting to do without the equipment set and excellent outcomes. So you have the best of both worlds between external and endonasal. And of course, the long-standing myth we busted that the ostium is bigger in an external TCR. That's all. Thank you.
What was the exclusion criteria in your study?
Exclusion in our study, in the MMC study, was any local cause causing epiphora, which could be entropion, could be lash, distichiasis, blepharitis, and all those local causes. Was all causes was trauma causing NLD obstruction. Was pediatric age group, so anything less than 18 was no. And last was it was an acute DAC was not included.
What about the suspected cases of rhinosporosis?
Rhinosporosis actually that's a good scenario. Now rhinosporosis most of the time in our cases lacrimal sac is only when we realize on the table. So in the rare scenario where we had a regurgitation on pressure and we thought there was no canalicular obstruction was also a exclusion criteria. So if there was a canalicular obstruction in one and we did the surgery because the Roplus was positive, then we did not include that patient because we were doing canalicular trephine in the other one. Similarly, if on the table we found that there was a dacrylolith which came out of rhinosporosis, we excluded that patient because we didn't want to include any case which would possibly affect one eye. Confounding factor. So I think, but I'll also talk about the downside. The downside is Now within our system, within LVP, there are surgeons who do endoscopy. There are surgeons who do non-endoscopic endoneal. But I think uh, what so essentially people who come to train with us, they get to see both. We never try to tell them that this is this is the only way to go. No. But the idea is that I think both in their own ways have the benefits. Depends on what kind of a scenario you're going to work in, what works for you. And I think at the end of the day, for all times as a surgeon, we need to remember what works in our hands. If you understand that much, you will always do good for the patient. If you realize that I want to benefit this patient, and for A, B, C reasons, because there is trauma, because there is this, whatever else, I think by doing external, I can do a good job. There's nothing wrong with external. So that's absolutely not the right thing to think about. But it is also important to always remember that as a surgeon, keep asking that question: when was the last time I did something for the first time? And if you keep asking that question again and again, you'll always keep improving. There's something next. There's something next. Right? So I think that's what keeps us going. That's all. Thank you.
Dr. Suresh. Smita. Now, dear students, we have learnt a lot from Dr. Suresh. Now, it's all of us know him, but we are blessed that he is here amidst us, teaching step-by-step surgery and also about this newer surgical method, that is non-endoscopic endonasal PCR. So now Dr. Asmita will tell us more, will speak of a small CV about Dr. Suresh Nathwar. Dr. Suresh.
ହାଇଟ୍ ଚଲେଇଛନ୍ତି ଆଉ ଏପର୍ଯ୍ୟନ୍ତ ବି ସରିନି।
Sir, sir,
ଆସିଲି ଦେଖାଇ ଆସିଲି ଦେଖାଇ
ଆପଣ sir
ବସ
to our campus. He is a network director, operations in charge. He is also the in charge of elderly eye care and home care services and consultant ophthalmologist at LVPI Bhubaneswar campus. The foundation to his medical career was laid in 1995 when he joined for his graduate course in MBBS at SCB Medical College and Hospital, which furthered his medical education for his MS education as well in 2000. Then he laid his steps into LVPI and joined as a consultant ophthalmologist in July 1, 2006, furthering it as a campus director in July 1, 2018, and now he is the network director of home care since July 2021. He specializes in ophthalmic plastic surgery, facial aesthetics, ocular oncology, and ophthalmic ocular prosthetics. The further academic endeavors include a long-term fellowship at L.V. Prasad Eye Hospital at Hyderabad, also a International Council of Ophthalmology certificate in 2002, and he is also a fellow of the Royal College of Physicians and Surgeons from Glasgow 2004. He also holds an international fellowship certificate from the University of British Columbia, Vancouver, Canada. As the heading shows, he is a man with many accolades because he is the man behind the expansion of ophthalmic plastic services at LVPI MTC campus Bhubaneswar. He has trained with the legendary Dr. Peter Dolman in oculoplastics at the University of British Columbia, Canada. He is basically the brain behind establishment of comprehensive thyroid eye care, a thyroid clinic at the LVPI campus Bhubaneswar. He is also in the executive board of Asia Pacific chapter of the International Thyroid Eye Disease Society. He is the principal investigator for the study of role of infections in idiopathogenesis of ocular adnexal lymphoma, which is funded by the Department of Biotechnology, as an editor of the textbook of Surgery in Thyroid Eye Disease, a conceptual approach, which is published by Springer. He has also received the Virac Big Innovation Grant. Currently, he is the project coordinator for the Tribal Odisha Eye Disease Study, funded by the Ministry of Tribal Affairs, New Delhi, which documents the eye health of particularly vulnerable tribal groups in Odisha and India, and which is the most interesting fact, as well as the academic hunger, which shows in the fact that he has authored about 67 indexed publications in peer-reviewed journals and 5 book chapters to date. So welcome and thank you for all the skills we learned today, as well as the academic education. Thank you.
Now we request our HOD Dr. K.C. Kudu sir and Dr. Sharma sir to kindly felicitate Dr. Suryasnanda today for all that he has done. He had a fabulous workshop. I want a big hand to him. All of you can come over here for a group photograph.
Today is not a good
You can
doctor only, or a clinician or academic. It is a very good gentleman. And he is very, very kindness.